Hi. So in this video, we are going to start benign prostatic hyperplasia. So let's start. First, what is benign prostatic hyperplasia? So you all know that hyperplasia means increase in number of cells, right? So here basically what is happening, prostate is enlarging. Okay, and this BPH is the extremely common cause of prostatic enlargement. Okay, and जो prostate है, it contains stroma as well as glandular elements. So in BPH, proliferation of stroma and glandular elements occurs. Okay. Now it generally occurs in the elderly male, commonly above 50 years of age. Okay. Now let's just see about prostate. So prostate is a fibromuscular gland, and here fibrous connective tissue is present. That is fibrous connective tissue, and smooth muscles present in the prostate. That's why muscular. So it's basically a fibromuscular gland. Okay, and it weighs around 18 to 20 gram, and site where it is located. So if you see the location of prostate, this is your bladder and urethra, and here your prostate located. Okay, so it is located at the base of bladder. So prostate is located at the base of bladder. Now lobes. You know, prostate is divided into 5 lobes. Those are anterior, posterior, 2 lateral, and 1 median. So 5 lobes are there. Now these lateral and median lobe enlargement occurs generally in BPH. Okay, and prostatic carcinoma arises most commonly from this posterior lobe. Now, on the basis of work of McNeil, prostate is divided into 3 zones. And what are these? Let's see. So here is a picture showing you all the zones of prostate, and if we see them, first is peripheral zone. So this peripheral zone is mainly located posteriorly. Okay, and this is the zone from where prostatic carcinoma arises mostly, and this contains 75% of glandular elements. Okay, now second is your central zone, and the central zone is located posterior to this urethral lumen. This is urethra, right? So posterior to this urethral lumen and above the ejaculatory duct. You know, ejaculatory duct present inside the prostate, so it passes inside of the prostate and then combine into the urethra. Okay, so this is central zone. Now third zone is the transitional zone, and this transitional zone gives rises to the BPH. Okay, now one more thing here, you know, prostate itself contains smooth muscles, you know that. Now at the neck of the bladder or in the upper part of prostate, there is a sphincter muscle that performs a sexual function. And what is that? It generally closes. Okay, it closes during ejaculation. So let's say during ejaculation it closes, and then it helps in inhibiting the retrograde ejaculation. Okay, because it closes, so retrograde ejaculation will not occur. But what happens during prostatectomy? This tissue is also got resected, and if this tissue got resected, then it will cause retrograde ejaculation. Okay, and that's why we say one of the complication of prostatectomy is retrograde ejaculation. Okay, now next, in this image you can see clearly 3 zones, that is central zone, transitional zone that you can see here behind the posterior to this, and this is the peripheral zone. Okay, and in BPH you know that transitional zone enlargement occurs. BPH arises from this transitional zone, and this transitional zone will enlarge and it will push this peripheral zone. Okay, because it will enlarge and it will cause pressure to this peripheral zone, and this peripheral zone will convert into a false capsule. Okay, it will form a false capsule. This is seminal vesicle, and you know that ejaculatory duct. Okay. Now here comes your pathology. So what causes BPH? You know, BPH is due to this 1,5-DHT. This is 1,5-dihydrotestosterone, and it increases locally. It increases, and how comes it happen? How it all happens? It all happens because of the testosterone, and you know that testosterone secretes from Leydig cells. Okay, so Leydig cells forms testosterone. Leydig cells present in the testis, right? So this testosterone got converted into 1,5-dihydrotestosterone with the help of 5-alpha reductase. 5-alpha reductase. Okay, what it will do now? Now, as testosterone converts into 1,5-dihydrotestosterone, its level increases locally in the prostate. Okay, and you know what? This 1,5-dihydrotestosterone is 10 times more potent than this testosterone. Okay, and it will, what it will do? It will combine to the receptor, nuclear receptor of the prostate, and it will cause hyperplasia. Okay, and this will lead to the, it will cause hyperplasia, and this will lead to prostatic enlargement. Okay, now histology. Prostate is a fibromuscular gland. Prostate is a fibromuscular gland. Okay, now it contains fibromuscular stroma, and it contains tubuloalveolar gland. Okay, and if you see the structure of the gland, let's draw it. It has one basement membrane. This is the basement membrane, and it contains basal layer. Okay, basal layer is formed basically of the flattened cells. So this is the basal layer, and it contains your columnar cells. So these are your columnar cells. Now these columnar cells secretes prostatic fluid. Okay, so this is the structure of prostatic gland. Okay, so there is one more term, that is corpora amylacia, and this corpora amylacia present in the prostatic gland, that is corpora amylacia. Okay, this is also present in the prostatic gland. And what is this? This is round eosinophilic bodies. What are these? These are the round eosinophilic bodies. Okay, these are basically nothing, but with time these secretions got calcified. Okay, this is what corpora amylacia is. Now let's see changes due to BPH. We have seen that this is bladder, this is urethra, here comes your prostate, and this prostate got enlarging due to the BPH. Okay, so if prostate enlargement occurs, this urethra gets narrowed down. Okay, narrowing occurs and lengthening also occurs. Other than that, what will happen? Yeah, urine and it will not able to pass. So what will occur? Yeah, urine store hoga, stasis hoga, and intravesical pressure will increase. Okay, क्योंकि यहाँ urine present है, it will cause the pressure increases. Okay, so यहाँ pressure increase होगा. Now what will because muscles present है bladder में, right? These muscles, what will they do? They will try to pass this urine. So they got hypertrophied. Compensate करने के लिए they got hypertrophied. Okay, and this hypertrophied muscles, they look like trabeculations. So changes क्या क्या है? यहाँ यूरिन कलेक्ट हो रहा है, स्टेसिस हो रहा है, पास नहीं हो रहा, यहाँ का प्रेशर बढ़ रहा है, और यूरिथ्रा के अंदर नैरोइंग हो रही है, लेंथनिंग हो रही है. Okay, so changes are trabeculations. I told you because of the increased IVP. Vesical diverticulum can form because of the raised IVP, and lengthening or narrowing of prostatic urethra. Okay, here in this diagram you can see that hypertrophy of trigone is occurring, that is muscle. Okay, so this looks like trabeculations. Okay, these are trabeculations. Then I told you in BPH या तो lateral lobe की enlargement होती है median lobe की. So this is the enlarging median lobe. Okay, and this is prostatic urethra, and these are further the lobes. Okay. Now clinical features. Okay. So clinical features basically median lobe is enlarging. So if median lobe is enlarging, it will cause the irritative symptoms. Okay. And lateral lobe is somewhat if they will enlarge, they will cause obstruction. As you can see, they will cause this urethra to narrow. They will cause narrowing of the urethra. Okay. And median lobe, so they will cause lower urinary tract symptoms, and median lobe will cause irritative symptoms. So let's see these irritative symptoms. Irritative symptoms are the urgency, okay, nocturia, urge incontinence. All these are irritative symptoms. And then nocturnal enuresis, okay, and increased frequency. These are the clinical features. Now if you see lower urinary tract or obstructive symptoms, so obstructive symptoms, what will they, क्या होंगे obstructive symptoms? First is hesitancy, okay, and this hesitancy will worsen if the bladder is very full. Then dribbling of urine, okay, poor flow, we can say poor flow, and feeling of incomplete evacuation. So these all are the clinical features with which patient will present to the OPD. Now there is one more term. This is bladder outlet obstruction, or we can say BOO. Okay, this is a urodynamic concept. Let's see what this is. Urodynamic concept. So it is basically the combination of increased voiding pressure and decreased flow rate. Okay, so this is bladder outlet obstruction. Here, this is your bladder, this is urethra, and this is your enlarging prostate. Now if prostate will enlarge, it will cause obstruction. Okay, here pressure will increase. Okay, that will cause increased voiding pressure because pressure is increasing and this path is narrowed down, and as flow rate will decrease because of the obstruction. Now bladder outlet obstruction has many causes. One is the BPH. Other than that, other causes are, it may be the bladder neck stenosis. Okay, bladder neck stenosis. And what are others? Others are like urethral strictures, then carcinomas, prostatic carcinomas. All these can cause bladder outlet obstruction. Okay, let's see here. So I told you there are many causes of bladder outlet obstruction. Now what are the effects on bladder of this outlet obstruction? First is, as I told you, urinary flow rate will decrease. Okay, this will become less than 10 ml per second, and voiding pressure will increase. Normally voiding pressure is less than 60 centimeter S2, but here it will increases up to greater than 80 centimeter S2, and bladder will be more irritative. Then complications of bladder outlet obstruction. What are those? Because in bladder outlet obstruction, prostate will enlarge and it will not cause it will not allow the urine to pass through it. Okay, so retention of urine can occur. Then bilateral hydronephrosis can occur, and infections, calculi, because urine stasis is occurring, and urine, is a good culture. So how we approach the patient of BPH? First is history. History is very important. Here is one scoring system, that is International Prostatic Symptom Score. International Prostatic Symptom Scoring. Okay, so this scoring helps us to measure the severity. Okay. Now abdominal examination. Abdominal examination, it consists same steps like inspection, first inspection, then palpation, then auscultation and percussion. Okay, same steps are followed. On inspection, what we see in BPH, urine retention can be there. Okay, so if residual urine, to check the residual urine, what will we see here? On inspection, the suprapubic crease will be absent. Okay, एंड अगर हम पाल्पेट करेंगे एब्डोमेन को, सो ब्लैडर विल बी पाल्पेबल इफ रेजिडुअल यूरिन इज देयर और इफ देयर इज retention of urine, right? Now rectal examination. If we do the rectal examination, then posterior surface of prostate, it will be smooth, it will be convex, and it will be typically elastic. Okay, and firm sometime because of the fibrous elements. And also we can feel the fluctuant swelling because of the residual urine. Okay, so fluctuate swelling can be there, it will be smooth, convex, elastic and firm sometimes. Then USG, on USG of kidney, ureter and bladder. Okay, now TRUS, another clinical modality then we can use to diagnose it is the TRUS, that is transrectal ultrasonography. Then uroflowmetry. This uroflowmetry, it includes basically the voiding pressure, measurement of the voiding pressure, okay, and measurement of the urinary flow rate. Urinary flow rate. Now this urinary, for the meaningful estimation of this urinary flow rate, 2 or 3 voids should be measured. Okay, 2 or 3 voids, and at least 150 to 200 ml of volume should be voided. Okay, in that we measure this urinary flow rate. Now this urinary flow rate will be less than 10 ml per second in case of bladder outlet obstruction or in case of BPH. Okay, and voiding pressure, as I have already told you, the voiding pressure will be more than 80 centimeter H2O. Okay, in case of this bladder outlet obstruction. So this is uroflowmetry. Then next is blood test. So in blood test we measure the creatinine levels, okay, glucose levels, electrolytes. So all these are measured. Glucose levels, creatinine and electrolytes, all these are measures. Then examination of urine. So we examine urine and we see the glucose levels, presence of blood in urine. Then bacteriological examination is also very important. For that we can take midstream of the urine and we can culture that, okay, to see the bacteriological examination. Now PSA. This PSA is also important. This is the prostatic specific antigen. Okay. Now what it will do? This PSA is glycoprotein. Okay, this is a glycoprotein, and this is a marker of the prostatic disease. It can be raised in the carcinoma, in the BPH, or in the prostatitis. So it is basically a marker of prostatic disease. But note one point, this prostatic PSA is not sensitive and not specific. तो ना ही ये sensitive है, ना ही ये specific है, because its level may vary. Okay, मतलब let's say its level can increase, can be more than 4 or can be less than 4 in case of carcinoma, in case of BPH. So not specific. Okay, so these are not specific. This is only the marker of the disease, but not here. If there is a male of 50 to 69 years and we do his PSA levels and we find that these are greater than 3 nanogram per ml, then this is the indication of biopsy. Okay, this is the indication of biopsy. Now management. So if we see the management of the BPH, so this management includes medical treatment and surgical treatment. It includes alpha blockers. We can give patient alpha blockers and we can give 5 alpha reductase inhibitor. Okay, what these do? Alpha blocker will relax smooth muscles, so it relaxes smooth muscles. 5 alpha reductase inhibitor, it will inhibit the production of 1,5 dihydrotestosterone. Okay, now surgical treatment is the prostatectomy. Okay, and for this we have 4 approaches. Now what are these approaches? If you see, 4 approaches we have. Okay, and first and foremost widely used is the TURP, that is transurethral resection of prostate. Okay, this is most common done surgery for BPH. Second is we can approach the prostate through retropubically, means behind the pubic bone. Okay, we can approach the prostate. Third is we can approach it through the bladder, that is transvesically. Then last is we can approach the prostate through the perineum. Okay, these all are the approaches of the prostate. And always remember, this transurethral resection of prostate is the most important. Okay, thank you.